Hello everyone and welcome to your channel. Imagine you are in an emergency department. A 4-month baby is brought in by worried parents. The baby has a runny nose and cough for the last 3 days. Since this morning, feeding has become difficult and parents have noticed rapid and noisy breathing. On examination, you find the baby is irritable, has a respiratory rate of 68 per minute, oxygen saturation of 88% in room air, subcostal and intercostal recessions, widespread fine crackles, and expiratory wheeze on auscultation. So, what is your diagnosis? What would you do next? If these questions make you think, then you are in the right place. Whenever you receive an infant with breathing difficulty, don't jump to diagnosis. Think. Always consider differentials. Could this be pneumonia? Possible. But pneumonia usually produces focal findings. Our baby has diffuse crackles. Asthma? Unlikely, because asthma is uncommon in a 4-month-old infant. Viral induced wheeze? But it usually occurs after 1 year of age. Can it be foreign body? But here the history would be sudden. Heart failure? Look for murmurs, hepatomegaly and poor weight gain. Not present in this case. So, most probably we are dealing with acute viral bronchiolitis. So today we will discuss bronchiolitis according to the latest UK guidelines with special focus on how it is tested in the MRCPCH FOP, TAS and AKP exams. By the end of this video, you will know not only the correct management but also how examiners frame questions on this common pediatric condition. Let's get started. Let's revise everything rapidly. Acute viral bronchiolitis is an acute viral infection of small airways. Respiratory syncytial virus is the commonest cause. It is typically seen in age less than 1 year. Symptoms include runny nose, cough, poor feeding, tachypnea, and respiratory distress. Common signs include crackles, wheeze, chest recession, and hypoxia. Diagnosis is primarily clinical. Routine investigations are usually unnecessary. Chest X-ray is not routinely recommended. Treatment is usually supportive. Oxygen is indicated only if SpO2 is less than 92% on room air. Maintain hydration. Remember, no routine salbutamol, no routine steroids, and no routine antibiotics. Consider admission if feeding, breathing, or oxygenation is significantly affected or if the infant has high risk features. If you can confidently recall these points, you will answer most MRCPCH bronchiolitis questions correctly. Now let us see how questions from this topic are actually framed for each MRCPCH theory exam. A 5-month-old infant with bronchiolitis is feeding well, has mild recession, and satisfactory oxygen saturation. What is the most appropriate management? A. Routine antibiotics. B. Routine chest X-ray. C. Supportive care with safety net advice. Or D. Nebulized salbutamol. What should be the answer? The correct answer is C. As discussed earlier, antibiotics, salbutamol, and chest X-ray are not routinely indicated as per the UK pediatric guidelines for bronchiolitis. A 3-month-old infant with bronchiolitis has worsening respiratory distress and repeated apneas. What is the next priority? A. Discharge home. B. Oral antibiotics. C. Escalate care and arrange PICU assessment. Or D. Repeat chest X-ray. Correct answer is C. Apnea and worsening respiratory distress is one of the criteria for admission according to UK pediatric guidelines for bronchiolitis. A parent asked why salbutamol is not routinely prescribed. Which explanation is most accurate? The answer here would be because bronchiolitis causes inflammation, edema, and mucus plugging rather than predominant bronchospasm, hence not routinely recommended. Recently, side effect of salbutamol also came in exam. Answer is lactic acidosis. Congratulations, you have now completed one of the most important respiratory topics in pediatrics. The purpose of this video was to give you an overview of how bronchiolitis is tested in the MRCPCH exam, how the theory is applied, and the style of questions you can expect in FOP, TAS, and AKP. For a more detailed MRCPCH focused presentation on bronchiolitis, I have linked the slide in the comment box. It covers the latest UK guidelines, exam-oriented concepts, clinical pearls, and high yield points for the MRCPCH exam. Do check it out. It will complement this video and strengthen your understanding of the topic. If you found this video helpful, please like the video, subscribe to the channel, and share it with your colleagues preparing for the MRCPCH. Thank you for watching, and I'll see you in the next video.